Thank you very much indeed. It's a pleasure to be back in Australia. I probably have come the furthest of anyone today. I think I can probably say that safely. It's a real pleasure and many thanks. And I will now owe Gina something for the advert for the books as well. But what I'd like to do is talk about how I see some of the things that are happening in how we look after people with MND. What are our aims overall with palliative care and MND in particular? It's to reduce the effects of the disease on the person, maintain the power that they have got, and most importantly, allowing the patient and family, it was interesting to hear about carers earlier today, to live as full a life as possible. And that means assessing the person. And I'm not going to just talk a lot about symptom management today, but there is a need to look at the physical aspects. That may be the symptoms, it may be the positioning and mobility. And those of you who have looked after people with MND know how you think you've got the best position and you're the bee's knees and it's all wonderful, and you leave the room and the buzzer goes, "Can you move me?" And you start all over again and again and again. And also the communication issues. I don't understand what she's saying. But there are the psychological, emotional, the social. Most of our patients are part of families, and the spiritual. There's great debate in palliative care what spiritual care is. It may be something religious, but it may be those deeper meaning of life. One of our UK MPs talked about the death of her father and her husband a short time apart from each other, and said, "I don't believe in God. Never have believed in God. I don't think I ever will believe in God, but I blamed God when my husband died." There's that deeper meaning. So what are the issues that are facing patients? The multiple losses, we all know. The physical, the cognitive, and I'd like to say a little bit more about that. The emotional. The person with emotional ability feels very strange, very frightened. The fear of the disease. If you look up MND on Google, you get some pretty awful things. You either get the wonder cure, only $100 a week. If you send us the money, we'll cure you. Or it's how you're going to choke to death. What information have people been given? And their fears of dying and death. And within the families, there may be very similar things, but there are often changes in roles. There's the losses of the person, of their relationship, their fears of what's going to happen with the disease, their fears of death and dying, but there may be some other very practical issues like finances. And the thought of filling in 108 pages to get money, I mean, most of us would balk after the third. And those emotional changes, he's not the same as he was. And let's think about the communication issues. We all talk about communication, how important it is to assess patients, to provide what they want, to make the best for them. But they're real problems. There can be real problems in the speech. I find as I get older and I've got some deafness, I'm finding it more and more difficult. What on earth is she saying? And if you don't get it the first time, you might get it the second time, but you darn sight won't get it the third time because anxiety levels are such. So how do we make sure people can still communicate? And then the understanding issues. Is there cognitive change? So we're communicating in a different way. And I think I've become more and more aware of cognitive change. As was said earlier, the actual frontal temporal dementia is probably only 5, 10, 15%. But I think the frontal lobe changes are much more common. And the more I look, the more I see. And there was the classification, this is an American, so it's in ALS. But looking at ALS, ALSCI with cognitive impairment suggesting 28%. With behavioural change, 39%, and with a dementia, 15%. So we're looking at a large number of people. But do we recognise it? And I think even more importantly is that the changes are frontotemporal. So there's going to be differences in attention, in cognitive flexibility, in word generation, in maybe a memory will be okay. So I also often see in an acute hospital, someone's done the mini mental state and they've got 8 out of 10, so they must be all right. But if you actually ask the family, this is a different person to the man that they married. Because those changes are going to be much more in cognitive loss, in psychomotor speed, in fluency, in language issues, and most importantly in executive function. Now I'm sure it's similar here. In the UK, everything is on choice. We must give patients choice for everything. If you've lost your ability to make executive functioning decisions, you can't make those choices. It's impossible. It may actually be really distressing. And I know I fight the system because everyone wants to give everyone choice. But how do we do that if we are starting to suspect a lot of patients haven't got those abilities? And I think there are issues for the patient. There's issues about decision making, about risk taking. Are people aware of the risk? We had one lady who verging onto frontotemporal dementia who, with her driving, when her husband said, "Follow me to the shops," she did follow him to the shops. 20 yards behind him, whether the traffic light was red, whether there was other traffic at the roundabout, whether it was going round a blind corner, she just followed him. So it made it quite dangerous. She couldn't visualise and see that risk. The frustration, the forgetfulness, the real concerns for the patient. But perhaps for even more for the family and how decisions are made. You know, we've always shared decisions together as a couple. And now you're not sure if that person's the same. They're saying something which doesn't fit with what they would have said before. Real issues, and the day-to-day coping, of the frustration, their fears of risk-taking, their language issues, the obsessive but impulsive behaviour. That same lady who wasn't very good at driving, her husband would say, "We're going to the shops later." This would be at 7 o'clock in the morning, and within 5 minutes she'd got her coat on, and she got her bag ready, and she was ready to go out to the shops. But they didn't open for another 2 hours. And we had to actually help him realise that he shouldn't be saying things too early, or giving 5 different choices of what shall we do today. And for us as professionals, how do we assess symptoms if someone has cognitive change? How do we cope with all those changes and the variation in perhaps a person's ability? We want to maintain safety. It may be difficult with feeding. I remember one patient whose swallowing was not very good, but when he took 3 chocolate bars and stuffed them in his mouth very, very quickly, his swallowing was appalling. And chocolate went everywhere. But it was very difficult because he could find a chocolate bar in that house that had been hidden, locked and double locked. How do we cope with the mobility issues of someone who perhaps still thinks they can walk when they can't? Of restraint. You know, maybe that person shouldn't be going out of the house. The husband has to go to work, he locks the door, she's locked in. Doesn't look very good. And then, do we give medication? Do we sedate? And I think also the multidisciplinary differences that can occur. And I'm more and more aware of the complications that we have for patients. We perhaps have the general practice team. We have a nursing team. We may have the specialist palliative care team. They're having NIV, so there's a respiratory team. They've had a PEG, so there's a gastroenterology team. They had to have a wheelchair, so they've been a rehabilitation team. That's 6 lots of people, all with the possibility of saying things slightly differently. You shouldn't, you couldn't, you may not. You know, that means different things. So we actually add to the confusion. Plus, perhaps the gastroenterologist hasn't dealt with MND, or did learn about MND when he was a medical student, because all medical students see MND patients because they've got lots of nice signs to be shown off. Cognitive change may not have been discussed 25 years ago when that consultant was actually undergoing his training. And so he's saying, she seems fine to me, you know, there's no confusion, no problems, whereas the rest of the team saying, we're not sure if she can make those decisions. And I think we can see conflict. Other decision making. How do we get assessments and help people to make decisions earlier, before their problems? But that may be before they want to discuss it. And I think that's a really difficult one. And I'm still challenged by that, of how do we discuss issues when we feel it's important now and the patient and the family are saying, we don't want to think about it. That maybe they have early cognitive change. Someone mentioned Stephen Hawking. I've never seen Stephen Hawking as a patient, but he won't change his communication system. It's 20 years out of date now. And he has one man whose job it is just to look after his communication system. I think he might have some cognitive change. I don't think I want to say that to him because I think there is a system where he can make a rude noise and comment on his system. But even at that level, are we seeing people who may have small changes that may give that rigidity, that lack of flexibility? And in discussions, we have a capacity act we have to do. Is the person able to understand the decision, make the decision, see the things that will come out of that decision, and give the decision back? Often, patients can do the first two, but the bit in between, the mulling over and seeing the implications of the decision may be really difficult. And doing that through a communication aid is even harder. So we need to be thinking and talking about quite difficult issues earlier. Now, as I say, communication, we're all committed, and I've been involved in a European Association of Palliative Care task force looking at guidelines for neurological care, including MND. And we came up with the areas that we wanted to look at was communication. It should be open. We should set goals and therapy options. Use structured systems to help with communication. Someone has to have the capacity and the ability to use that. But we also said the advantage and the need for early advanced care planning. But especially if we're thinking of communication issues and we're thinking of cognitive change. To make an advanced decision, talk that through on a communication aid is quite difficult. It can be done, but it's difficult. It's easier face-to-face where you get the nuances of the language and your speaking. But we then, again, may be facing someone who doesn't want to talk about these things. I'm a believer that many of these things should be done as a process. Like the insertion of a peg, I think, is a 6-month time. You've got slight problems with your swallowing, we may have to look at something. It's got a bit worse. Have you seen or heard about a peg? Would you like to meet someone with a peg? Would you like to see the dietitian and talk about it? We need to make the decision. And that's over a period of time. And I think we have to do the same period of time with other decision making, whether that's advanced care planning or non-invasive ventilation. We need to give people options and time to take it in, talk about it and come back, and hopefully before they have cognitive change that makes it more difficult for them. And then I think the other problem is the increasing problems I can see of all the interventions we do. We do a PEG and we do non-invasive ventilation, maybe doing diaphragmatic pacing in the future. But does that stop people talking about other things? They get so caught up on the peg. They get so caught up on that machine. What knobs do I twist? What do I do? How much am I using it? That we start not talking about the fact that the disease is still progressing. That actually the intervention is not going to cure MND. You are still going to progress. You may feel better. It may be very useful for symptom management. Do we still discuss dying? Oh, I'm better now, so I don't want to talk about that. Do we start preparing families? Look, these things are deteriorating. We need to think ahead. And do we do advanced care planning? And apologies, some of you may have seen this gentleman. He was a man who we were looking after at home, and one of the nurses was visiting him and said, oh, it's really sad, he's got prostate problems now, on top of having MND. Isn't that awful? A little bell rang in my brain. I went to see him, and he was waking up all through the night. And being a good Englishman, every time you wake up, you go and pass urine. You know, that's what you do. That's what your mum told you, and that's what we do. And he was going to pass urine 6, 7, 8 times a night. Having problems sometimes, because, wasn't much there, but he was still trying. He started on non-invasive ventilation, and his prostate was cured. And for the first time in 6 months, he had breakfast. He had been anorexic, not wanting to be bothered with things, feeling very down. But the first morning, having had 1 night on non-invasive ventilation, he had breakfast because he felt so much better. However, this photo is taken 6 months later, and this is several years ago, so we hadn't really talked through what was happening. And on his communication aid, he wrote, I wish I hadn't started this system. I'll leave it to your imagination what the word was. Because he now couldn't swallow. He now couldn't walk very well. His communication was very limited, just to the communication aid, and he really felt his quality of life was poor. But he also said, I can't stop it now. I feel I can't stop it. He could have stopped it, but he was linked in. And I think the more we see people with non-invasive ventilation, the more we have the risk of someone with a tracheostomy. This gentleman actually went in for a knee operation and came out with a diagnosis of MND and a tracheostomy. At the end of the operation, that bag that's supposed to go in and out at the end of the operation was sort of not doing anything, and he wasn't breathing, and then they thought that would perk up in a bit. And it didn't, and he was in intensive care unit and had a tracheostomy, and then 2 days later someone examined him and said, oh look, his hands look a bit funny. Oh, let's do the reflexes. Oh, they look a bit funny as well. We better get a neurologist along for this. And so he was diagnosed with MND. But I think we will see more and more people who will either be asking for tracheostomy. I'm on the internet to someone who's got a tracheostomy in America and they say it's wonderful. I want one, please. Or on Sunday afternoon, and it's always Sunday afternoon when the problems start, that they will land up in an emergency room and everything will in respiratory failure, and Monday morning everyone thinks, oh, what have we done? We better call the neurologist, who goes, oh my goodness. And I think we need to be talking about what's going to happen before we start non-invasive ventilation, before we start to insert the peg. But that may be difficult because people don't want to hear it. So again, we're faced with that dilemma. And then if we think about advanced care planning, I know these are the UK words which will be a bit different to Australian. But in the UK, we can have an advanced statement, which is just, I'm the sort of person who doesn't want to be ventilated if something happens to me. It's not a legal binding thing, but it gives a good idea of what sort of person you are. An advanced decision to refuse treatment is what the second gentleman you just saw did. He had his tracheostomy, he'd been in hospital for weeks, he came into the hospice and said, I want to go home. Took her time to organise to get 24-hour carers and get him home, but he then said, I do not want to come back into another hospital again. If something happens to this, I will die, won't I? So he said, fine, if that's how you feel, we will make it clear. So he did an advanced decision, refused treatment, to say he wouldn't want his tracheostomy refashioned, he wouldn't want to be admitted, and he died very peacefully at home. When there was a slight problem, he needed an injection, and he died very quickly. So that is a legal document. And if an ambulance crew had gone and resuscitated him, they would be at risk of being sued for assault and battery. I don't think anyone has yet, but it will. Or you can make the lasting power of attorney, where you give that decision over to somebody else. But there are other things that people do, whether it's the will, whether it's the funeral plans. How many times have we seen patients' families after the person's died and they say, we don't know, do they want to be buried or cremated or, shot up in a rocket into the sky or scattered over Sydney Harbour? Have they made those decisions? We don't know what hymns to use. We know ones what not to because they hated those ones, but we know, we want something a bit more positive. And also the place of care and the place of death. And those are two different things. I've been caught, I've talked to someone about where would you like to be, and they said, oh, at home, please. And then the day before they looked so ill, the day before they die, the wife says, well, he can't stay here because I can't live in this house ever again if he dies here. He's got to go. Why didn't you tell us? Well, you never asked us. You said, where did you want to be? And that's where you wanted to be that day. You didn't say, and in the future, when you are going to die. And the more I do in palliative care, I think even within palliative care, we sometimes don't like using the D word. She's ever so poorly. Ever so poorly means you don't go to work. But for us, ever so poorly means Cheyne-Stokes breathing and about to die any minute. It may not be long. It may be only a few weeks, gets turned into many weeks, a few days turns into many days, and we need to actually say the D word, dying and death. And I think we're very good at the euphemisms. And there are enough of them, of the euphemisms. You remember Monty Python and the dead parrot? There are lots of different ones. So what about end of life? Should we be looking at end of life care from diagnosis? We know, the diagnosis may be quite a shock to patients. I think Rob said earlier, there is that time, do you start saying too much at that time? But it's often suspected. And there are those fears, because most people do go home from seeing the neurologist and look up on Google now. We had a patient who'd seen a very good neurologist who'd been told in a wonderful way, very nicely, came out of the room and someone in the reception area said, here's the number of the MND Association. You'll need them when you get your wheelchair. They'll get it for you quicker. And don't look up things on the internet because it only talks about choking to death. All that good for the previous hour went. We worked hard on that, but I don't think those two things ever went from that person's mind. The choking to death was there in big block capitals in their brain and in their family's brain. So I think we need to be very careful and that people will find out information, and we need to preempt that and be starting to make those discussions. The other area I've seen recently is people with previous experience. We've had patients with familial MND who say, my mother died 20 years ago and it was awful. There wasn't any palliative care then. She had a horrendous death, and that's in the back of their minds. So I think we need to be looking at end of life at many stages. It may be at diagnosis, and for some patients that's right. They want to talk about it. There may be particular interventions like gastrostomy, NIV. There might be crises where there's been a deterioration, perhaps admission to hospital, or it may be just in the last stages of terminal stages, but I think we should be trying to avoid that. In the UK, we've had this end-of-life pathway. The idea is that there's discussions, there's assessment, then there's careful planning and care. High-quality care would be provided in all areas. The last few days would be fine. This was in the days when we had the Liverpool care pathway, so that was all sorted out until it was taken away as it was being misused. And then the care after death. But importantly, it also says about spiritual care and family care at the bottom. And I always think we say about support and care for carers, professionals are carers as well. If we have a crisis within our team, it's often the MND patient in the hospice. Doctors cope with stress in the UK very easily. We have a high suicide rate, a high divorce rate, and a high alcohol rate. But we don't have any stress. But do we think of ourselves and all the other people involved? For the gastroenterologist, it may be very stressful to actually be talking about a peg to someone he doesn't know, and he knows he's going to die, and he's frightened he's going to cause things to be worse. And there are decisions that may need to be made as life comes to the end about resuscitation, about sedation, about feeding and hydration. Euthanasia has been mentioned. Patients will ask, and we need to be able to talk about it. There's no easy answer. We can say, well, we can't do that, but we can do these things. And I know one patient handed over a book and said, look, doc, just put the pill on it, please. That's all I want. I just want out of this as quickly as possible. Just put it on there and we'll be done. I said, I can't quite do that. There's a few rules and regulations, but would you like to make an advanced decision to refuse treatment, to go into hospital, to have ventilation, would you like to make sure no one will resuscitate you? Would you like to make sure medication's available so that you can have a crisis cope with at home? Okay. It's not what I really want, but we'll keep talking about it. And then we've looked again in the UK about what there might be triggers to make us think that we are coming to the end of life. This is for all neurology patients, so it may be at their request. Dysphagia, cognitive decline, dyspnea, repeated infections, particularly aspiration pneumonia, weight loss, that gut feeling we come down to of the marked decline in condition. That always doesn't look quite right. We've all had, and you think, I'm not surprised that something's happening. We also look particularly at MND that breathlessness and respiratory failure we know is a bad prognostic sign, that the swallowing issues, the cognitive changes and the generalised weakness. Now these were just done as a consensus and there is no evidence-based. Someone mentioned evidence-based earlier, except one unit went through 60 deaths of patients and looked at how often those triggers were occurring. And as you can see, the nearer to death, the more triggers there were. We're repeating this with a bigger survey, but it's looking that if you've got at sort of 6 months, you may have 4 or 5 triggers, and aspiration pneumonia is the top one. It looks more and more, if you've had an aspiration pneumonia with a neurological disease, your prognosis may be months. So it's starting to make us think. So what are we aiming to do? To control symptoms, to anticipate crises, to support the patient and the family? and the carers. That may be us, it might be social carers who are providing day-to-day support. Do we ever ask them how they're feeling? Now, I know you don't have the just-in-case kit in Australia, but just as an example, what we've tried to do is to have this programme where there'll be discussion about end-of-life issues or what may happen from the patient's point of view and the professional's point of view. And it provides a box. That's what the box looks like. I mean, it's just a box. I use high-tech versions of this, ice cream cartons. It goes in the cupboard. The GP can then prescribe the medication, and there's a family end which might have buccal midazolam, and the other end would have morphine, midazolam, and glycopyrronium or hyoscine, scopolamine. So the medicines are there for the Sunday afternoon, because that's when the problems always happen. So it's preparing, having them ready so that a nurse can come and give an injection rather than getting a doctor to come and give a prescription to someone to go and get the prescription and come back again and it's all too late. So where are we? I think it's a real challenge within palliative care, how we look at palliative care and MND and neurological disease. When I started, which is a long time ago, 32 years ago, I first walked into St Christopher as a junior doctor, and 38 years ago as a medical student. There was that at the top. You had active treatment, it stopped, and then you pass them over to that lot. You know, you had your laparotomy, which was open and closed, and you were sent down to the hospice. That's changed over the years, and more there's cooperation. You know, one service may do a little bit less as the other service does more. But Peter Bede in Ireland has suggested that it may be more like this, that there's a coming and going. At diagnosis, someone needs a lot of support about how to cope with the diagnosis, what to tell their family, who to tell, how to do it. At gastrostomy, at non-invasive ventilation, whether they happen or not, but they're issues. And then in the final stages. And there may be an up and down input, and that's a challenge, because in the UK you either have palliative care or you don't. And increasingly we're being told you get funded for what you do or you don't. So having someone sort of a bit in the background who you contact once in a while doesn't fit into any funding system. But I think it is a challenge, and it's a similar challenge for other diseases as well. So, to conclude, where are we? It is individualised care, as has been said. We are looking at complex issues, the physical, psychosocial and spiritual. It is multidisciplinary, but with all the difficulties that causes. And I think we tend to minimise multidisciplinary problems. You know, we all work perfectly together. Except that respiratory physician. Oh. He always says the wrong thing. And we're trying to maximise quality of life and hopefully quality of death. Thank you.
Excellent timing. So, questions for David?
They're all full of lunch.
Dr. Oliver, I'm Rosemary from Port Macquarie Palliative Care. One of the problems that I'm up against is somebody with motor neurone disease who has a peg inserted, getting towards the end of life. Discussions haven't been able to be done early about when the time comes, do we reduce the feeds, how do we go about this? Carer is reluctant to reduce because that's a sign that they're getting closer to dying. How do you deal with those situations?
I think commonly it doesn't often seem to be an issue, that often families are reducing. But sometimes you can say, look, they don't seem as comfortable when we're doing the feed for a long period of time as they were in the past. Perhaps we should reduce it a little bit and just see how they are. Not stop it, because stopping is, feeding is such an important part of life, isn't it? Particularly for carers. My mother, until she died, still would go when I was eating my tea. It was a long time since I had it spooned in. So it's not stopping, or it may be, shall we put a bit of water in now rather than the feed, and trying to gently change one to the other. I think if they carry on with the feed, as long as they're not regurgitating and aspirating it, you're not actually going to be doing much harm, because the respiratory issue is going to finish them sooner than being dehydrated. So I think it's trying to have that discussion, but you say the idea is to have some of that discussion earlier about what are we going to do. And it may again be over a few days. Shall we just reduce it from the 2,200 to 2,000 today? And we'll see in a couple of days. Well, I think we could leave one of the bottles off, so we're down to 1,000, and put some water through. And it's sort of a process rather than a sudden decision. I think more and more, if we can do that in decision making, it makes it easier for everyone. Does that sort of... There can be. The other issue of withdrawal is obviously with non-invasive ventilation. And that, ethically, my brain is fine. Ethically, you're withdrawing a treatment that someone doesn't want. Down this bit is saying you pushing a button and the person dies. And there's a conflict between those two. And that's much more sudden as a change. And that again within the team may have lots of different views of what we're doing. And we need to address those before someone rings up the local newspaper and says, Dr. Oliver's killed someone off today. I always had problems because Howard Shipman used to have a grey beard and glasses, and one or two patients said, I think I saw someone like you on the telly. Not me, not me.
Another question. Time for one more question.
Annie Kavanagh, I'm a speech pathologist from Cairns. I often see people really early on in diagnosis and this concept of death. I think the first person I ever worked with, the first question I ever got asked was, am I going to die? And I had 5 minutes of thinking, what does he know? What's he found out? He could see it on my face, but said, don't worry, I know I'm going to. It was just, I could give him a different answer. So the question I have for you is, whose responsibility do you think it is to talk these things with people? Given that not everybody that they meet straight up is going to be a palliative care specialist, should we have some specialist training when we're actually seeing it for the first time, do you think?
Now, looking at the palliative care, do you want to say you need to expand your services by 500% and take over all decisions? Or I think it's all of us. And it's part of our general training that we haven't had any of those things. I mean, doctors are coming through who've had an afternoon or two with an actor to talk about breaking bad news, and you can see there, this isn't, I'm not trained, and often their training has been saying how not to do it from other doctors rather than how to do it. So I think it has to be, the person who's giving the diagnosis needs to be honest to where they are and what the prognosis is. Now that may be on a second occasion rather than a first. And I think anyone, if we're confronted with what's going to happen, we all have to say it there and then as much as possible. We can't say you have to ask someone 2 weeks' time when you're at your appointment, because it's lost. But that's quite difficult for all of us. And I think there is something about us having the training, and also to have someone to go back and say, you never know what happens. Oh, can I have 10 minutes and a cup of coffee, please? Because I always say if it isn't difficult for me, I should stop. Because if you are saying something very dramatic and very final to someone, if you're just doing, yes, you are going to die, on autopilot, you're not doing it properly. So if it doesn't get you, you're not doing it. It's probably becoming a bit rote. So actually, if you know it's difficult, you're there. But it is asking for other support from other services, and it may be better for some, to say, actually, can I come with somebody else next time? We can talk about it again, or I'll have a colleague come in to see you and talk about some of those issues separately.